Good afternoon. Well, please, Melissa, Laura, Alejandro. Thank you. Welcome to the people who is connected also to this session. Are you ready to dance? It's not a joke, huh? We used to dance in the Chagas session always. Okay, let's see later. In order not to lose too much time, let me introduce you. This is, we take it very seriously each year, the COR-NTD session. And in order to submit a proposal to the COR-NTD organization, we just make a poll of different topics that we perceive that is important to tackle, depending on which we want to advocate or depending on which we want to show about the current situations or current important priorities in the Chagas community. We ask Chagas patients, we ask Chagas experts, and finally we make a poll and we vote, aim on the organizations of the Chagas coalition and other friends and allies and people outside the coalition. And this year was selected the alternative methods of diagnosis for Chagas disease. And when we select the topics, there are always people who volunteer, support us with contents, logistical issues and whatever. And this is the group of the moderators. We are more moderators than participants sometimes. But they are not only moderators. I mean, they are people who provide content, ideas, and support during the process of building the session together. So that's why we are always on time at the end, and we reach the deadline to submit the proposals many times because we work it during the whole process, and it's a learning process. So sometimes it's very interesting to watch and to attend to the learning process and to receive the different ideas. And sometimes those ideas are so exciting that when we reach to the session, they don't share with the same passion that in the process. We expect today that is will not happen. I mean that we expect from you to provide your same passion and ideas. So, well, sorry, my name is Javier Sancho from the Chagas Global Coalition, and let me pass the microphone to my colleagues, moderators.
Hi, I'm Victoria Periago from Mundo Sano Foundation.
Hello, I'm Laura Borges. I'm Scientific Officer at the NTD program at FINE.
Hi, I'm Melissa Nolan. I'm an Associate Professor at the University of South Carolina.
Hello, I'm Alejandro Schichman from the National Council of Science and Technology of Argentina.
Thank you so much, guys. Thank you for your support and help to build this session. I hope that we can reach a consensus. I mentioned the dance before, because in the annual meetings of the Chagas Coalition, we had the big objective. Our main priority maybe was to learn each year one different dance of Latin American countries. We started with the merengue session in the last annual meeting of the Chagas Coalition in person. The problem was that comes the pandemic, so there was no in person. So next time we will see what kind of dance. But dance together is very important for us because at the end, dance is try to reach a consensus between each other. That is our objective today, not to dance, I mean, is to reach consensus, to reach recommendations. Our main objective is, after the presentation, we are going to have a discussion. We are going to divide in two groups. We have divided already the groups. We are going to call you for group 1 or group 2 after the presentations. And the idea is, in Chagas disease at least, there is sometimes controversial discussions between open the door for alternatives to the conventional methods for diagnosis. That's why it's so important, because now that the door is open at least for the discussion, for the validation process, and especially the door opened by PAHO and by WHO in order to receive your inputs. You are the experts on this. The idea today is to try to bring here almost all the context, all the consensus reached until now, and try to write together a paper. So the discussion today, the dynamic, is to write together a paper. It's not a dynamic only. The idea is to write really a paper after this session as a deliverable of this session. It's a position paper. Obviously, it's not a paper based in scientific evidence completely. It's more position paper, but we hope that at least 4 or 5 minimum consensus we can reach in that discussion. If we don't do it, we need another session for the next year in the COR-NTD in order to reach that consensus. But we hope to at least to have one, 2, 3 consensus to write a paper together after the session. You will be co-author with us in that session if you agree with that. So no more time I steal, and I pass the word to our introducer, moderator, Melissa, in order to introduce the speakers.
I think you can all probably hear me. Oh, for the online, okay. So I have the pleasure of introducing our first speaker today. Laura Borges is a scientific officer at Find Diagnostics in Geneva and Bogota. She leads the Chagas Disease program based in Colombia, and her work focuses on ensuring diagnostic innovation and accessibility for resource-limited populations. Please welcome Dr. Borges.
Do I need to use the microphone? Okay. Let's see. Maybe, yeah, it's fine. Okay. Well, I prefer standing, but the microphone is not helping quite a bit. But well, first of all, thank you very much for the introduction. And I want to thank my colleagues of the Chagas Global Coalition. We are FINE, are members of the coalition, and we foster collaboration and synergies in research and development of new tools to fight the disease, improve access to diagnosis and treatment, and care for the affected communities. Special thanks to Javier, because he's always encouraging us to bring these discussions and create the spheres and the platforms of discussion outside the Chagas community, going beyond with the entities, communities, and engagement with the civil society. I want to thank you. But this is not my presentation. Okay, this is it. Okay, so I'm going to briefly, 10 minutes, introduce a landscape on diagnostic tools for Chagas disease. What are the diagnostic tools available, the gaps in diagnostics for Chagas disease that we identified, and the steps to move forward. And maybe 2 minutes. Okay. Yeah, much better. Just before starting, 2 minutes of the importance of this discussion today. The countries in Latin America have started since the 90s years, control, and they have had different strategies to control the disease. In the 90s, they were especially focused on controlling vectorial infestation in the houses. Also, leveraging on the screening of HIV, they had strengthening the control of transfusional transmission in the 90s, and they had large progresses in these two, controlling these two modes of transmission. However, nowadays, the key challenge is to control congenital transmission. But the diagnostic tools that we are and the countries are using nowadays are the ones that they were developed in the 90s, when the priorities of the countries were totally different. We want to foster the discussion today with you, especially to learn also from your experience in other disease programs and even beyond the NTD programs, to understand also the effective successful or even unsuccessful and effective strategies in the maternal health care initiatives that we could apply in Chagas disease to improve the control of maternal or congenital transmission in Chagas disease. So I'm going to briefly explain what is the technology landscape and the diagnostic tools that we have mapped. So that if we want to be in the same page, so to say, I try to simplify the diagnostic gaps for Chagas disease in a graphical representation. This is a very complex disease and health program. It's not only a biomedical issue, it's also a psycho-social challenge for the health programs, but I'm going to try to keep a simple graphic representation. We can see the disease progresses starting from an acute phase of the infection, shown here in purple, that it progresses towards a chronic infection or chronic stage of the disease, shown here in green. This is a life-lasting condition that it can progress toward the symptomatic condition that is actual Chagas disease with cardiac disease and systemic congestion. This is a life-threatening condition. The majority of cases nowadays are estimated to be asymptomatic chronic condition, shown here in green. Because this is also a silent and mainly asymptomatic condition, the countries focus on the priority populations that are the most reachable groups that seek care or can be captured earlier. And they are shown here highlighted in purple: children born to seropositive mothers, pregnant women and women at fertile age, and children in the affected communities, shown here in green. The current diagnostic tools available are mainly for the acute infection, microscopy and parasitological methods, and a couple of countries are implementing molecular diagnosis like PCR in Argentina or Chile. In the case of the chronic, the majority of cases, the current standard is agreement of at least 2 laboratory-based tests, like ELISA and direct MR agglutination and direct immunofluorescence. So this diagnosis is currently performed at the second level facility or higher. There is a treatment available. However, the efficacy is the highest the younger the person is, and also the earlier the infection of the stage of the infection. The treatment is not prescribed for pregnant women or the cases with a severe chronic condition. This is important because I want you to remember the 2 legs for dancing, as Javier wants to put this analogy, is we want to focus for Chagas disease in an early detection. We are not interested in a late detection with the tools that we have now available. We cannot afford that. And we also want to focus on an integrated or comprehensive care so that we accompany the affected populations through time, even if they are eligible or not for the treatment that is available. So these are the 2 key things for Chagas disease. What are the options for filling these diagnostic gaps? Mainly, what are the options that try to incorporate the primary health care also in the health or strengthening the health systems? And these are the new tools that are proposed. There are rapid diagnostic tests that could be as an alternative to the laboratory-based tests. We will go more in detail about these. Also, some tools that improve parasite detection, like molecular diagnostic tools. And they are highlighted because there are some tools available we have mapped. But the main testing gaps that remain are especially tests for disease of progression. So what are the cases that really will develop this severe chronic condition? And also a test of treatment that we can follow up the patients once they receive the treatment available. I want to direct you in more details about the information in a report that we have published in 2022, mapping this technology landscape. It was performed within the consortium Cuida Chagas, sponsored by UNITAID and the Brazilian government, and technical authorities in Latin America together with FINE. This consortium is led by my colleague, Andrea Silvestre, here present in the audience, and you can refer to more details of this published here. We also use this information feeding the NTD test directory at FINE that is available, and you can register also new diagnostic tools that are under development or commercially available. What are the key insights? There are 112 diagnostic tests for Chagas disease available or under development worldwide. The majority are immunoassays, shown here in red, 103 immunoassays, and only 9 molecular diagnostic tests, including 8 qPCR kits commercially available and 1 LAMP test for isothermal point-of-care diagnostic tool. The majority of these diagnostic tools here shown in red are with a regulatory approval, so they are already registered. And the ones that are in the late development state or with regulatory achieved, it's interesting for NTDs. We have 25% of the very fragmented market with more than 50 manufacturers. The 25% of them are located in South America. This is not common for NTDs. And also, as expected, the majority of them are laboratory-based tests. If we focus in the first diagnostic gap that I mentioned for chronic infection, we have 103 immunoassays shown here. And 40% of them are lateral flow assays or rapid diagnostic tests that they could strengthen their use if they are used in primary healthcare or in different use cases. In Latin America, with the key 4 countries of interest of the consortium, Bolivia, Brazil, Colombia, and Paraguay, we have mapped that of these 39 RDTs, 14 are commercially available or have regulatory approvals in the Latin American countries. Very important of the insights of this market assessment is that they have more than 70% of them have a stringent regulatory approvals from reference authorities. This is an enabler of market access because they have achieved high standards of quality and regulation. The major barrier for acceptability and adoption of these diagnostic tools is the lack of independent evidence about their performance. And I'm not going to, for the sake of time, I'm going to skip a few slides, but we at FINE, together with our partners in the region, including DNDi and the Cuida Chagas Consortium, are generating independent evidence about the performance of these RDTs in different countries, including laboratory evaluations and on-field evaluation in multicentric prospective studies. And finally, the second gap that we mentioned in acute infection, we only have 9 molecular diagnostic tools that could improve the current diagnostic algorithms. These are in a regulatory achieved, the majority of the qPCR kits, and only 1 LAMP diagnostic tool under validation. And in an early stage development, some other tools. So just to summarize what I already mentioned, these are the diagnostic tools I mentioned, could simplify the diagnostic algorithms, and we remain with the diagnostic gaps in disease, stop a test for disease progression and a test of treatment. With that, I just want to mention that this information is available in these websites where we want to connect and have free open platforms to connect developers and users of the buyers of the potential diagnostic tools. Key points, and with this I finalize, that we perceive it's important on the steps to move forward, including focusing on open data, is to have updated target product profiles with the key opinion leaders and the countries involved in the development and update of these so that we guide and inform product developers, as well as improving biobanking services to speed up development and evaluation of the new diagnostic tools. Thank you.
Thank you. Excellent talk. Our next speaker is Marcelo Abril. He's the Executive Director of Mundo Sano Foundation. He facilitates the No Baby with Chagas Disease initiative with the goal of preventing all congenital cases by 2030. He brings a wealth of experience on government, community, and practitioner relations, having been with Mundo Sano since 2002. Welcome.
Thank you. Thank you. Thank you for the opportunity. Thank you to COR-NTD for include Chagas in this session. And well, as you can see, the title of my presentation is in a question form. But really, I want to say that my pretension is not to provide a definitive answer to this question. Instead, I am to share some practical experience carried out by Mundo Sano in different regions and areas of Latin America and other countries. Well, as you know, the complexity of mother-to-child transmission of Chagas disease requires a comprehensive understanding of the associated factors of the disease. The first reality check we find those willing to work in favor to promote diagnosis and treatment of Chagas disease most of the time is to reach to a place to put at the service of the people the existing tools as the ELISA diagnostic kits, the other clinics exam, the available treatments, the two available treatments. Nothing seemed to be a great challenge, but in fact, what we want to do is to do what should be done according to the current reference guidelines, but the really show that it's not functioning really. However, lack of interest or knowledge from healthcare providers and as equally serious, the lack of demand from the affected people place us at the current state of affairs with Chagas disease. And in this situation regarding Chagas disease, mother-to-child transmission should also be considered especially, regardless of the existing evidence that the control of this way of transmission is possible, and that in every place where pregnancy controls are provided, there is an opportunity to include Chagas disease and work towards its elimination. Our approach from Mundo Sano involves a variety of strategies promoting access to diagnosis and treatment through 5 interventions in different scenarios, participating in research activities, for example, the Chagas Lamp and Nuestro Ben. We also work on advocacy through Chagas awareness campaigns and aiming at influencing public policies of the governments in our region. We work with the governments too at the initiative, Ibero-American initiative, Not a Single Baby with Chagas, of which we are the technical unit. Finally, since 2012, Mundo Sano has been committed to ensuring the global supply of Benidazole. We work to identify and overcome access barriers to diagnosis and treatment of Chagas disease. Our work is carried out mainly, but not only in Argentina, comprising endemic and non-endemic areas, as the case in the great urban conglomerates such as Buenos Aires metropolitan area. Outside Argentina, we have been working in Spain for several years, besides importing and distributing benidosol manufactured in Argentina to ensure the availability. And we work with Latin American migrant communities in different regions in Spain. In addition, and along with local partners, we have carried out activities and will continue to do so in other countries of Latin America, such as the case of Guatemala. Here in the United States, together with Insud Pharma, we registered benidosol in 2017, the first FDA-approved treatment for Chagas disease in this country. Now, in this slide, we can see some of the projects we have been involved in the last year. I'm going to give you some details about them. The first project is sport, childhood, and Chagas disease. With the participation of the Barcelona Soccer Club, the main objective of this initiative was to raise awareness about Chagas disease through sports and recreational activities, and to reduce its impact in communities through the Gran Chaco region of South America. The activities began in Argentina in 2015 with sports festivals as an excuse to perform a screening test, were implemented in the town of Añatuya, Santiago del Estero province, in 2016 in the town of Juan José Castelli in Chaco. Later, on 2017, the same strategy, the sport festival and testing campaigns, was carried out in Muyupampa, Guacareta, and Monteagudo in Bolivia, and finally in 2018 in Presidente Ayes and Paipucú in Paraguay. A total of 2,058 diagnoses were conducted with rapid test and serological confirmation of positive cases. A total of 113 samples from the sport festival were confirmed as positive results. This project proved to be a very positive experience in which advocacy and awareness activities were combined with access campaigns for diagnosis and treatment of Chagas through the promotion of values in the practice of non-competitive soccer. I mentioned the use of rapid tests in this project. We use them because we consider that it was the only feasible way to carry out the screening activities in a sport field with hundreds of children and youngsters. The project did not aim at an evaluation RDTs. They were used with the fail-safe of using conventional serological techniques to confirm the results of positive samples. Another projects are related with the implementation of the PAHO strategy, EMTCT Plus framework for the elimination of mother-to-child transmission of Chagas and the other mother-to-child transmissible diseases. In this case, we have been implementing this project since 2018 in the area of the border of Argentina, Paraguay, and Bolivia, the Chaco region of South America. It's a very, very difficult access rural area with population spread through the territory and belonging to different ethnic minorities, each of them with their particular culture and practices, including nomad groups. A total of 2,535 rapid tests were conducted, including 2,231 pregnant women, near of 200 children born to mothers with Chagas disease, and more than 100 newborns over 10 months old. Among them, the 5% test positive with rapid tests, of which the 86% were confirmed by serology. Field work is organized around pregnancy periodic controls. It requires a demanding effort for patients, registration, and follow-up, considering that women lack a permanent home resulting from their nomadic practices. Well, I understand that the time is out. 2 minutes more. Thank you. Okay, this is other kind of project. This is an investigation project. Only to mention that as the implementation organization in Argentina, Mundo Sano select the province of Santiago del Estero, and we work in 2 maternities, the Hospital Intersonal Ramón Carrillo at the capital of the province and the Centro Integral de Salud of the city of La Banda. A total of 2,559 rapid tests were conducted, including near of 500 pregnant women, postpartum women, and more than 140 newborns older than 10 months. 8% mothers tested positive on both the rapid and serology tests. I would like to highlight especially that this research provides the opportunity to insert the Chagas attainment in the biggest maternities of the province of Santiago del Estero. The last project I want to comment, the name is Let's Think About Chagas. And in this case, it's implemented in a non-endemic area of Argentina, in a locality that is named Almirante Brown, less of 40 kilometers from Buenos Aires. In this case, the work is carried out in the healthcare centers located in the most vulnerable areas of this locality. And the first activity is to do a brief questionnaire regarding risk factors linked with Chagas disease. In case that this questionnaire results positive, then the person receives orientation to achieve a diagnosis of Chagas. At the same moment of the questionnaire is did, we offer a rapid test for Chagas, and posteriorly we have the opportunity to confirm the results with serology. A total of 133 rapid tests were administered, out of which 32 results positive for Chagas disease. In total, we use almost 6,000 rapid tests. From the total, 419, 6% tests were positive for Chagas disease. Except for Chagas LAMP, in all the other projects, rapid tests were the only available alternative to provide access to a preliminary diagnosis for Chagas. This is the real situation. It is the only alternative. We consider that include this kind of project together with the local responsible for the healthcare of the population is a good alternative to promote the attention of Chagas disease in all this variant of projects. And the time is out, then I consider that it's enough for you and for me. Thank you.
Just to, hello. Just only to tell you, we are in a challenge. The challenge, salsa. You know where the salsa was born? Salsa music? Where it was born?
Colombia.
You don't know?
Colombia.
Some people say Colombia, and others say Cuba. But the reality is that it was born in New York, in the Bronx. So as usual, the United States appropriating our traditions, but anyway. So, but when you learn salsa, you say it's very easy, no? It's one step forward, one step back, and then, it's something really manageable, a little bit, no? But when you go to Cali, to the town of Cali in Colombia, you discover that the salsa is 100 faster, and it is impossible. I mean, you can die there if you try, but we need to try. Now, our partner in dancing is the time, so we had the challenge of time. For the rest of the speakers, I beg you, I need to request to you, be faster in order to reach the time.
I don't understand, Javier. We having time for my presentation and having time to talk about salsa and the origin of salsa.
The problem is that he's an expert in tango music, but he doesn't understand it. So please.
Okay, well, the next speaker needs very little introduction. I think most of us probably know her. Maria Jesus Benazo is the head of Chagas program at DNDi. She's a physician by training and has brought this expertise into her current role, where she coordinates diagnosis and treatment programs across South America. Welcome.
Thank you very much. Speed is my second name. So, no, I will try, but I speak a lot. I'm Andalusian, even speaking English, so if you don't understand me, please let me know, and I try to slow it down and try to make it comprehensible, at least understandable. Sorry. So, this is the epidemiological situation. By the way, I'm the head of Chagas program at DNDi. 3 minutes? No, impossible. So I will try. But in 3 minutes, it is not going to be possible. Epidemiological situation that you perfectly know, but the only point I want to highlight for you is that remember that the real bottleneck that today we have in Chagas disease for control is diagnosis. As DNDi, our main focus is to develop therapeutic strategies, new therapeutic approaches, but without people diagnosed, it is not needed a treatment. So we are also involved in that because of this reason, just to put this in our minds, because we are not going to find in a few years, even if we collaborate as we are collaborating, the perfect solution to give to all these people that are attending for the diagnosis and then the treatment. So we have already agreed that one of the main priorities in terms of diagnostic needs for Chagas is, for sure, a test of early assessment of treatment response, because if not, we cannot give the response to patient, neither develop new therapeutic strategies, but also a point-of-care test for congenital Chagas disease is if our goal to 2030 is to control mother-to-child transmission. So these are the two main priorities that we have agreed inside Chagas research colleagues that work on that. I don't have now I'm nervous because of time. So these are the two priorities that we have. So, in which point we are? We know that we have a serious access problem with millions of people at risk waiting. A question to be addressed that must be addressed through scientific evidence, that it is the performance of the RDTs that we have at that moment. And we also know that there is an issue and a challenge with RDTs availability on the market. So we have to address these three topics. First, internal validation, that it is evidence. What happens with registration in order to have a wider access, and then how we are going to implement that. So, for the first topic, DNDi and colleagues, we have been performing performance studies of RDTs in the field in Colombia, Guatemala, and Argentina. The scenario in Colombia, lab scenario, and in the field in the other two countries through implementation research approach in Argentina, in serum, in laboratory context, but in capillary blood when we are speaking on field conditions. And this was the population and sample size that were there, RDTs we evaluated, and taking into account that the official algorithm at that moment in the three countries are based on ELISAs. Then the results, as a super summary of the results, very good performance in Colombia and in Argentina. It is not the same situation in Guatemala. But here is when I remind you that there are less than 10% of people diagnosed. So even if we don't have the perfect tool, if ELISAs are not reaching people that are needed to be diagnosed, we have to work on search for the best strategy to diagnose those people. When we did the study in the case we did that to try to see what were the performance in duo. We did it in Guatemala in order to increase a bit the sensitivity. Was not the expected one, but at least was a little better. So then we have to think what we should do in this situation. And the perspectives that we have in the three countries is in Colombia to do on-site evaluation, and it is linked to mother-to-child control. I'm going to tell you about that. In Guatemala, to search together with collaborators there what is the new approach we should to think about that. And in Argentina also to make the field evaluation. I'm going to skip this slide. And then I want also yeah. So in terms of, I think it is also an important point because after having this sensitivity and specificity and a scientific data and requirement that we know to move forward no matter what the strategy, then we have to face the other side of the challenge, that is the registration. In terms of registration, and Laura started to mention that, but the approval by international agencies that are not mandatory linked to Latin America is required by companies, also in Latin American companies. So it is important to keep in mind that requests from no Latin American countries are sometimes difficult to afford by Latin American ones. So we need alignment on that, and we have to work at any other levels besides giving evidence on that. And regarding different registration standards and regulation, there is a lack of harmonization between these registration rules. Also at that level, we need to better align. And for that, here we have the Latin American and Caribbean medicine agencies, but it should be supported by country regulatory authorities. If not, we cannot move forward. And on the other side, we have the PAHO Strategic Fund that should also support this kind of process and conversations and alignment. So this is 2 or 3 different levels in which we should work in. And regarding implementation, just to remember you something that you know, but it is important to implement that at country level, that is that the process of registration and approval of this diagnostic test are costly and require resources that in the most of the times countries don't have. So it is important that government recognize the relevance to register the RDTs to ensure and speed up the processes. And sorry for the typo. This is about production. Industries and companies are not always interested on the development because of costs, because of there is many diseases and things that are for the industry more relevant than NTD, so we have also to work on that. So it's no sense to have this evidence on our hands if then we cannot move forward the registration and the production of these RDTs. Just to let you know that we have been working in the 2 contexts, in Colombia and Guatemala. In Colombia was easier, but even if in this better scenario, it was not possible the acquisition of the best RDT that we know that we have to implement in Colombia. Because of these problems that I told you, there were no production at that moment, and it wasn't registered in the country. So in these 11 RDTs we tested, it wasn't included in BIOS 1. The good things that in terms of implementation, that thanks to this test or these studies that we did in the country, we have had the possibility to train health personnel in the use of RDTs, that it is easier, but it still requires technical specificities that are important to train people on that. And also the sensitization of at-risk populations with whom we worked at the time. And we take advantage of the experience, and we did an out-of-pocket study that showed us, it is already published, by the way, that speaks in favor of the use of RDTs. Even if RDTs are more expensive than an ELISA and one ELISA test, but the cost of people, the out-of-pocket expenses of people going to a second or third healthcare center is super high in comparison with the cost of the RDT. So, but it is not possible without registration and inclusion in the algorithm of these RDTs. In Guatemala, just to let you know that the situation was even more difficult than that. There was not appropriation of the process by the authorities, so we have to work harder on that. Just a kind of a super quick summary. And in the context of mother to child, so what were the uses of, what are the uses that we have for these RDTs in the context of chronic Chagas disease? For screening, for sure, it's a big game from my point of view, from most of us' point of view. And in mother-to-child easy detection, it has a high sensitivity required. We cannot skip or miss one single case because of the topic of mother-to-child transmission. So we need super high sensitivity and specificity, but remind this less than 10% of people diagnosed. So we are missing these mothers at the end of the day. So this is the situation, and we are in conversation if based on this evidence that we have, it could be also feasible to use it as diagnostic test. So in the context of mother-to-child easy detection, we are at that moment doing a study in the field testing the performance of RDTs in pregnant women in Colombia. So it is a prospective study. The population is pregnant women. This is the sample size, and we are doing that with blood. So we will have three potential diagnosis scenarios. That is the use of RDT duos in these three potential uses: RDT plus ELISA or RDT plus two ELISAs, taking into account what are the costs of each one of the three situations, that it is not going to be always feasible in the field. So, and in terms of decentralizing test and treat, the best option for sure in an ideal world is RDT2. And I think that I have insisted in the take-home messages. You have it there, and in favor of time that I have spent a little more than 3 minutes. So I leave the floor here, and thank you very much.
Thank you. Okay, and our next speaker is Julio Padilla, who's an assistant professor and co-director of the Chagas Initiative at IS Global Barcelona. Is he here? Virtual. Okay, great. And his laboratory works on diagnostics and novel therapeutics for Chagas disease.
In this COR-NTD meeting, although remotely, I am sure I cannot be there in person with you. I'm Julio Alonso Padilla from the Barcelona Institute for Global Health, and I'm going to talk about the field validation of T-cruzilan, a molecular point-of-care test for the control of congenital Chagas disease. First of all, thank the main funder, the IFIC Fund, for the opportunity to perform this project that has been made possible by the Chagas Lamp Consortium. At the time I'm recording this presentation, the project is not yet finished, will be ending at the end of September. And these are the organizations that have taken part of it, with also being thankful to a remarkable co-funding by Fundación Mundo Sano. The working area implementation of the project has been made in the laboratories of 9 hospitals with maternities, 5 in Bolivia, 2 in Argentina, and 2 in Paraguay. And the study design on the flowchart of the study is as shown here in this slide. Note that it is basically a scale up of a pilot study that was made in the Bolivian Chaco 2018-2019. What we've made now is adapt that first study and scale it to the 9 hospitals I mentioned before. The series of events in the study depart with the serological diagnosis of the mothers, and we take advantage of this first activity to compare ELISAs to RDTs. At this moment, we have screened over 7,400 mothers. And then we arrive to the longitudinal part of the study that involves different visits to the newborns, to those T. cruzi infected mothers. We're taking advantage of the different tests and sampling points for the current algorithm. We collect extra samples to perform the experimental test that we compare also with the standard molecular test, the qPCR, at 2 times. And then in the serological study, by 9 months of age, we compare ELISAs to RDTs. The numbers of this longitudinal part of the study say that we enrolled 640 newborns to T. cruzi infected mothers. That number decreased in the next 2 visits, and we've ended up with over 530 newborns that have been followed up the 3 visits. In terms of the results, RDTs versus ELISAs at this moment in the screening of mothers, because we are yet analyzing the RDTs versus ELISAs with the infant results, but the general overview in adults of the 9 sites indicate that we have a very, very high specificity of the RDTs, above 99.5%, while their sensitivity was not that good, slightly over 75%. But if we look at the results on a per country basis, these boxes show the number of women that were screened in Bolivia, Argentina, and Paraguay. We can see that the agreement of the RDTs to the ELISAs in terms of the positive detections, as we mentioned before, that the negative detections were very high, but the positive detections in Bolivia were very, very high, the sensitivity, almost the same. Not as good as it's been in Argentina, where we see that the RDTs managed to detect half of the ELISA positive cases only. And in Paraguay, the issue is that the seroprevalence rate we have found is below 2%, and the number of positive detections will very probably not allow a statistically robust comparison. In terms of comparing the T. cruzi lab results, and these 2 tables show the aggregated results from the first and the second visit. The one on the left compares the LAMP to the micro method. The other one is the LAMP compared to the PCR. When comparing to the micro method, we see that the LAMP managed to detect almost all, only missed 1 positive micro methods, and we really need to look what's going on with this one. But remarkably, it found 13 extra cases that the micro method missed. In terms of LAMP against the standard molecular test, very good agreement in the negatives, and also good agreement in the positive, much higher obviously than with the micro method. And this translated in a kappa index of 0.74 comparing LAMP with liquid blood against micro method, and 0.84 comparing LAMP with qPCR. Please note that we also ran a sub-study comparing the LAMP on liquid blood or dry blood spot samples, and you can check those results in Dr. Schichman's InnovaLab presentation. Finally, I would like to thank, obviously, all the organizations involved in the project, and thanks to all study participants and all the biochemists, nurses, and operators, technicians that participated. And please stay for the video, the dissemination video of the Chagas project that I think it's going to be shown right after this presentation. Thank you very much, and I hope you enjoy the meeting. Bye.
Ser oportuno.
Okay, so our next speaker is Andrea Silvestre, who's the principal investigator of Guida Chagas at Fiocruz, Brazil. This multinational consortium brings together experts across South America to implement research, community engagement, and diagnostic clinical innovation into practice.
Lambada or samba? Samba, samba. Thank you very much, Melissa and Javier. I will try to speak faster, but I will use the presentation from Maria Jesus. We know our problem. We have lots of people and the low levels of screening, and it is a major limiting factor in assessing care for Chagas disease. And we know our goal, WHO roadmap, action against neglected tropical disease is core for universal health coverage and contributes to achievement the Sustainable Development Goals. And in these documents, we have the target for elimination Chagas disease as a public health problem. We have to increase the number of countries with interruption of the transmission, and the congenital transmission is a very important problem for us. And we have the MTCT Plus initiative from PAHO, and two important projects, the Ibero-American Summit and Cuida Chagas project, the first neglected tropical disease searched by UNITAID, involved in congenital transmission and elimination the congenital transmission of Chagas disease. You know the barriers that we have to assessing diagnosis, and like Maria Jesus said, for us, we have lower than 10% of people with diagnosed, and we have later diagnosis. So most of the people in the very poor conditions, and when cure maybe is not possible. It's because we have a low suspicion, and majority of these people are asymptomatic, and we have a very limited decentralization for these diagnoses. So needing large geographic movements from these people. And until now, we need two different serological tests with costs, with need infrastructure and a qualifier team to perform this test. So we need to work with actions of information, education, and communication, not only for health professionals, but to community. It's very important to mitigate this problem. And it is essential to decentralize the care and focus with a focus in primary health care. However, the last document who was produced from PAHO in this year, they don't mention the RDTs to use in these conditions, even to screening these people. So we have a big problem with advocacy here. The way we have in the roadmap, WHO defined some priorities to assessment these gaps for diagnostic, and we have to work validating the RDTs and point of care diagnostics. We know this. Talking something about the Cuida Chagas project, we are working to contribute to the elimination of congenital transmission of Chagas disease by scaling up and enhancing the access to diagnosis, treatment, and comprehensive care through innovative and sustainable approaches in 4 different countries in Latin America: Bolivia, Brazil, Colombia, and Paraguay. We have some outputs working to evidence generated on effective test, treat, and care approaches through implementation research, by work in the community and civil society engagement to increase the demand for diagnosis. working together, our colleagues from FIND, validating a new algorithm for diagnostic and market to ensure equitable access for these tools, new tools. And in the implementation research, we want to demonstrating how testing, treat, and care interventions can contribute to overcoming the barriers and improving access and demand for diagnosis, treatment, and care for Chagas disease for these women and the children, and performing the situation analysis and proposing specific intervention for each territory that we are working. And proving the feasibility of RDTs for screening and integrating MTCT Plus, and very important, performing the cost effectiveness analysis of these interventions. Here we have some examples that our work, we operated based on agreement with ministers of health and managers. It's very important advocacy to introduce these new tools in these countries. And we can highlight the work with the community mobilization, increasing the demand for diagnosis and from a well-informed population. And this population needs to be co-responsible for their own care. And we have some intersectorial actions, like here, working in our places at schools. Our local team working with these children, talking about Chagas disease from some comics like Turma da Mônica, who is very important in Brazil. And a very important capacity building for people in primary care, the health professionals, from some methodology of trainers. We developed some models at Fiocruz campus here online, but we have presential models. And here we have the people, for example, here, the professionals from Pará in Brazilian Amazonian area, the doctors, nurses, and our local team in Rio with our central team. They were training, and here the same doctor training at Amazonia area, the other doctors talking about Chagas disease, not only clinical comprehensive care, but how to use the RDTs for screening and counseling. And finally, we believe that it's essential to act through point of care and diagnostic tools like RDTs for screening with decentralized diagnostic algorithms. And through these large-scale screen actions, we will increase detection the people in early stages of the disease. It's very important, who can and should be cared for in primary care, and also increase the access for diagnosis, treatment, and care for new cases of vertical transmission. And we believe that action, in this case, integrating Chagas disease in other care actions like MTCT Plus or other promotion activities, we can guarantee the sustainability of these actions. Thank you.
Thank you, Andrea. Thank you. Just to add to the presentation, something that is not related to this presentation, but recently in Brazil, the patient movement you know that in the Chagas community, we built together the design of a symbol, because Chagas had no symbol to identify themselves in the past. Now we have a symbol that is the color green and brown, and we have a T-shirt that shows a little bit the fight for Chagas disease and the World Chagas Day. And recently in Brazil, the patient movement bring the Chagas T-shirt to the President Lula da Silva. And he's the first president who dressed the T-shirt. not technical. I mean, not exactly dressed because the T-shirt was so striped. But anyway, he shows his support. Maybe we get more and more presidents. Maybe the United States can bring the T-shirt to Donald Trump. I mean, to Joe Biden. Sorry. The patients. Yeah, the patients print T-shirt. Yeah. Sorry. Sorry again. I propose you with this last presentation, the last show by Jaime Alche, the Tango Time, 1 minute show. I propose you to let the questions to the speakers for the coffee breaks. I mean, you can approach the speakers and share your question with them, because the most important part will be the discussion later, okay? Thank you.
Okay. Well, the problem is, see, I spent 10 years in Texas where we learned the Texas two-step, which is probably 1,000 times slower than the Colombian Cali dance. So I could be up here all day too. So our last speaker is Jaime Alche. He's the director of parasitology at the Hospital de Niños Ricardo Gutierrez in Buenos Aires, Argentina. He's authored almost 200 articles, I believe, from your Google Scholar page on pediatric formulations of nifurtimox and benznidazole, treatment response, and developing better test for kids in mind. Thank you.
Last presenter, only 1 minute maybe, no? Well, I have been working during several years about Chagas disease, but now I will talk about other diseases. The organization asked me to talk about problems with other diseases that could be applied for Chagas disease. Well, this is our hospital. We work in a small place here. We have the Chagas. I belong to also to the CONICET and several institutions. Next, okay. Well, I will center the discussions about perinatal infections and the different challenges about Chagas disease. The majority of infected newborns are asymptomatic. Then the only way to diagnose a newborn is from the universal screening of the mother. This is one of the critical points about that. In symptomatic cases, clinical signs are common to several infectious agents. Then this is the common presentation. Then we need the information from the mother. This is a critical point. We have the limited sample availability. I have been working with, for example, Alejandro Sigma during the last 20 years with PCR, and we discussed about the same. We need more amount of sample. That is impossible with newborns. We have a small amount of sample. We have the problem of the passive transfer of IgG from the mother to the baby blood. Then the serological tests don't have a real scenario for diagnosis of congenital infections. We have low interest in the industry for the development of IgM markers of infections. This is also a critical point for several diseases. And about biomolecular tests, we saw in different clinical trials false positive and false negative results using, for example, PCR. Then this is another item to discuss. Not only Chagas disease, but I will show you. Given these challenges, healthcare providers often rely on a combination of clinical assessment, laboratory testing, maternal history, and risk factor to diagnose perinatal infection. We need the health systems, not only a new diagnostic test. This is also a critical point. We have the combination of the natural intelligence, not the artificial intelligence. We need the natural one. Timely diagnosis and appropriate treatment are crucial to reduce the risk of complications in neonates and infants, and for Chagas disease, for the development of complication in adults. This is an example of a problem. With HIV, we have the problem of the window period. The window period is from infections and the appearance of the immunological response for diagnosis. What happened? We developed different tests in order to resolve the problem of about the window period. We have a combination of serology and antigen detections, and also the development of biomolecular tests in order to resolve this window problem. This is more information about that, but the critical point is this one. Only one test is not enough for diagnosis of HIV perinatal infections. Why? Because we have false positive results. And we are observing the same phenomena in Chagas disease, in congenital Chagas disease. About syphilis, we are working hard in syphilis diagnosis, but this is another neglected diseases. Why? Because we have a lot of patients with syphilis currently around the world, and we have the same test over the last 100 years, maybe. The treponemic and non-treponemic test. The BDRL is an old one, one we are continuing using. And we don't have any test for the diagnosis of congenital cases, because then the diagnosis is based in the epidemiological risk base. Every newborn born to an infected mother has syphilis. But about 50% of them don't have this real syphilis. This is about risk. Then we are treating a lot of patients, a lot of uninfected patients. We have the problem of passive transfer of antibodies, and no biomolecular diagnostic tests are available for diagnosis. We are working about that. We are working in the genotyping of Treponema pallidum in joint venture with Washington University currently, but we don't have results about that, but we are working about that. Other disease, infectious disease, tuberculosis, we have a lot of patients with tuberculosis, but they found this test, that the expert test, that with a cassette you can make a rapid diagnosis in 2 hours. This is another example where we have a problem and they found the resolution. And this is recommended by international organization. They buy the equipment and is distributed around the world. And now it is also used for HIV diagnosis also. About perinatal infections, the diagnostic test must be validated by clinical trials, none by expert opinions only. We need the clinical trials. Data from selected sample or population are not enough. A critical point is the sustainability in the production. We have to have the product for several years. If not, it's not valid to make any clinical study. Not always the new test is the best. It has to be affordable by the country. The diagnostic tool have to be adapted to the local health systems. This is also a critical point. A point of care has different meanings for different people from different countries for different scenarios. This is a critical because all the people talk about point of care, but the definition of point of care has different meanings. This is also a critical point. Okay, thank you very much.
Thank you, Jaime. You fixed the time. I mean, the only one, I think. So now we have a coffee break, and then after the coffee break, we are going to be shorter, to take it shorter, maybe 10 minutes, 15 minutes, because we need your help to write together the papers, at least to draft the main points of the paper after the coffee break. So please take energy with the coffee, and then you can approach the speakers if you have specific questions. Thank you. 10 minutes, we'll be back here, okay? We know that it's 15 minutes, you know that, but officially 10 minutes.
Bueno, la noticia que recibí es sobre los resultados de mi enfermedad, del Chagas, que salió positivo. Y ¿quién da?
Please come back, people. If I go outside, you hear my microphone, yeah?
Como que me identifico mucho acá porque acá están todos los latinoamericanos.
Exacto.
Pero no es en español, ¿no?
Estamos usando ahí medio, porque lo que pasa es que como hay gente de Estados Unidos, ¿no?
Un spanglés.
Spanish total, Spanish.
Está bien, está bien. Qué bueno.
¿Tú conocías a Colin, por casualidad? Es del DNDi, él trabaja en Estados Unidos, pero conoce bien, sobre todo Bolivia, trabaja mucho en Bolivia. Él es antropólogo, tiene una visión integral de
Después si
luego
de repente me lo presentas. Que les vaya muy bien, ¿eh?
Gracias. Is everybody? Hello, Chagas session, please. It's going to start again. They don't hear me anyway outside, no? Okay, we're okay. We are gonna share a part of the video that was we lack in the first part of the presentation. This video is about the methodology of LAMP.
Estudio, el beneficiado va a ser aquel pequeño, aquella pequeña que nazca y no tenga estas complicaciones a futuro. No van a heredar este tipo de cosas. Vamos a cortar ese círculo que es totalmente negativo y realmente va a ser oportuno.
Para detectar el Chagas, que viene de hace tiempo, una persona que se ha infectado hace más de 10, 15 años, la prueba es la misma en Bolivia y en toda Sudamérica. Es una prueba confirmatoria que se llama ELISA y esta busca detectar los anticuerpos en la persona, ¿no? En el caso de los bebés es un poco más complejo porque lo que se trata es de ver la forma viva del parásito en la sangre, donde la sensibilidad, donde el índice de exactitud que tiene es un poco bajo.
Thanks to the fact that some infected mothers are diagnosed promptly, their babies can be diagnosed and followed up from the moment of delivery and during their first year of life. However, current diagnostic methods present several challenges: efficacy, cost, and above all, a slow and complex process of tests and repetitions. Based on the first months of microscopic observation to detect the presence of the parasite in the blood of infants. The low sensitivity of this search implies that generally the diagnosis must culminate in a serological study when babies are 9 months old. That is to say, every child born to a mother with the infection must return with their mother to the health centers and laboratories 2 or even 3 times during the first year of life in order to be able to complete their own diagnosis. But for various reasons, they don't always go back.
Pasa que con la prueba convencional que tenemos ahora, se le da un resultado a la mamá negativo, se le explica que debe volver para confirmar ese resultado, pero la mayoría de ellas no vuelven. La mamá lo ve sano y dice, ¿para qué voy a volver? Y no vuelve. Y resulta que el niño sí tenía Chagas, pero los síntomas no los va a desarrollar hasta que sea adulto.
The good news is that a new molecular amplification method called Chagas LAMP can change this process. The LAMP, capable of detecting the presence of the parasite in the infant with greater efficiency than current microscopic methods, is faster and easier to use than other molecular techniques such as PCR.
¿Qué ofrece esta tecnología? Ofrecería un diagnóstico temprano de Chagas congénito y, por tanto, un acceso al tratamiento de manera rápida, evitando las pérdidas, que ahora mismo es una de las problemáticas más graves para dar acceso a tratamiento a los niños afectados por esta enfermedad.
Many mothers and their babies are participating in the Chagas LAMP study, which is being carried out in 3 countries in the heart of South America. The results observed so far give great hope that LAMP is also cheaper than PCR, as it does not need expensive equipment to be performed. The LAMP method could be the solution for the early diagnosis of congenital Chagas disease, which would have an enormous impact on the goal agreed upon by the countries affected by this disease, to eliminate it as a public health problem by 2030, so that no other child will grow up with it because they have not been diagnosed and treated on time. The LAMP method will contribute to avoid it.
Yo a las mamás que tienen Chagas o recién que se van a enterar que no se dejen, ¿no? Que se hagan pruebas. Yo le aconsejaría que hagan tratamiento, ¿no? Para prevenir, ¿no? Que no es tan difícil.
Thank you. Thank you. So before dividing the groups and before starting, we are going to just to place a little bit the context and the current situation in different areas of the diagnosis. Sometimes it's controversial because we part from a question that we need to reach more people, or we need to reach the people with the highest quality of the methods. So there is a tricky question sometimes, but in Chagas we need to make a balance on that. So let's hear very briefly, some experience and some backgrounds and some other experience about this dialogue hold with in different scenarios, in different events, and some news in some specific countries. And first of all, as taking into account that we are in the United States, let's see what is happening in the United States. So please, Melissa, brief it a little bit about that.
I will be very quick, I promise. Well, it really is a joy and a pleasure to be here. It's my first time at COR-NTDs. And so I just wanted to say a few words about where I think we are in the United States. I think we've seen incredible progress, really, over the last decade. When I was coming up as a grad student, there were only a handful of people. And so it's been exciting to see in the last several years a new generation of researchers and applied clinicians that are showing interest in this. In particular, we have a couple groups that are really leading the charge, getting more providers aware. So there's the Chagas Echo sessions by Dr. Paula Stigler-Granados, which is funded by the CDC, who works not only on clinical aspects of this disease, but also bringing attention to veterinarians and research and other aspects so that we can have a larger conversation about the needs around this. There's also the U.S. Chagas Disease Physician Network that's being led by Dr. Ava Clark, Karen Byrne, and Jeff Whitman, being supported by Mundo Sano, and they've done a wonderful job of really trying to get to those primary care physician providers to educate them on Chagas disease and why they need to be thinking about it with their local populations. There's certainly a research group being led by Colin Forsyth and Claudia Herrera, and then others. Daisy Hernandez is someone that's really made a big impact. If you haven't read her book, The Kissing Bug, I would highly recommend it. She's done a wonderful job of bringing a personalized attention to this here in our country. There's been enhanced recognition of Chagas disease cases. We know that 300,000 people in the United States are infected with this disease, but yet sadly still, similar to what we're seeing globally, less than 1% are actually treated. A big issue that we have compared to other countries is that we have a more diverse, somewhat foreign-born Latinx population that we need to focus on. And we know that there is a large gradient in the efficacy of our diagnostic test. So for example, some of the work we've done with Central American, foreign-born Latinx residents here in the United States, they show much worse, as kind of demonstrated by the Guatemala work, than in other countries such as Bolivia and Venezuela, and yet they tend to be higher numbers here in our country, and so trying to think about how we can develop better diagnostics for our local patient populations. Something really exciting that's happened in the last couple years in the United States around diagnostics is there was a big effort by a lot of the people here in this room to push. So now for all HIV infected individuals that would be at risk for having acquired Chagas disease in their home country, they are now screened. This is huge because this just happened the last couple of months. So now it's covered by insurance, whereas before, even though it was recommended, if it's not covered by the funding to support these already vulnerable populations living with HIV, now they have the ability to get treatment and have proper care. So that's been very exciting. As I believe was mentioned earlier, we've now broken down a lot of the treatment barriers. So Mundo Sano's helped get benznidazole recognized here, and Nifurtimox is also available. So then there really is this impetus now on diagnosing patients because we can provide them care. And then lastly, I just wanted to say there's been a strong commitment to novel diagnostics and therapeutics here in the United States. The National Institutes of Funding, or National Institutes of Health, currently has $13.6 million in funding to researchers across our country, looking at basic science and translational research, including some novel diagnostics. Which is Rick Tarleton's group at the University of Georgia is looking how can we incorporate 3D printing as a way to help substitute in some of these diagnostic challenges. As was mentioned with LAMP, we know that we can't develop these kind of sophisticated diagnostics that don't have real world use, so how could 3D printing help supplement some of that need? And then there's also Laura McCall at the University of Oklahoma who's doing basic science approaches to developing new diagnostics. And then last, I just wanted to say, when I did a quick search in the last 5 years, there's been over 900 articles by US-based physicians and researchers on this topic. So again, I think that really brings home the sentiment that in the US, we're really taking this disease seriously, and it's an exciting time to be a part of it here. So thank you for having me.
Thank you, Melissa. Thank you. It's so good to know that whole landscape about the current situation in the United States and how the United States is getting more and more interested in Chagas disease. It's very important for us. And now, news time. Something happens, something changed in Argentina. And it's not the president, not yet. Please, Alejandro, can you brief us a little bit what happened in Argentina last year?
Okay, in November 2021, our Ministry of Health decided to join, like we were 22 people working on diagnosis of Chagas disease, devoted to the solution of the early diagnosis of babies born to seropositive mothers. And we presented our experience and our data, and we had to write a report. We joined, I think, about 1,500 results from babies born to seropositive mothers, showing that the PCR was adequate in sensitivity and specificity and was better for early diagnosis than the micro method. And after that report that was sent to the Ministry of Health, a few months later, the new national guidelines for the official algorithm for diagnosis of congenital Chagas disease changed. And the algorithm, instead of saying parasitological diagnosis or micromethod or microhematocrit, now it says micromethod dash PCR. So, because of the pandemics, many more laboratories have to learn how to perform standardized real-time PCR for, of course, for SARS-CoV-2, and now they can perform with the same infrastructure the PCR for Chagas disease. And now we have, at the same time, we presented the data from new commercial kits. At least we have 2 in Argentina, and there's another one in Brazil. And there were also data from that. And so the government distributed some kits to those reference laboratories that were doing COVID diagnosis and now can do congenital Chagas disease diagnosis. So there was an important step forward, allowing the people to have access to this diagnosis. And now I'm working in the Chagas Lab Consortium. And like at the end of last month, we have the results comparing this PCR with a lamp with 500 babies. And the results are very similar in sensitivity and specificity. So I hope our next step was going to make a report with more experience to add lamp to PCR that will, I hope, that will allow to perform early diagnosis of babies, not in the places where they have a PCR, but in places where PCR cannot be done because of many different restrictions. Because as you have seen in the video, only with a water or a heater and a bench, without the need even of a centrifuge, you can perform the lamp test. So as we now have done this in 9 maternities linked to hospitals, some peripheral hospitals, and the performance is excellent. And another possibility is not only to perform the PCR for a very small, the lamp, for a very small volume of blood, which is 30 microliters, but only to perform it from FTI, from dry blood spots, that we can transport at room temperature to a laboratory. So I think we have a good road to, okay.
Thank you so much. And well, that is good news. Good news that countries are more and more flexible and accepting alternative methods. So just to finalize this part, before the discussion, this discussion that we are going to hold here has 2 recent precedents. Probably has more, but we highlight two precedents. One discussion that it was held by DNDi 2 years ago, and Colin Forsyth is going to brief us a little bit about the conclusions that can feed a little bit our thoughts about the discussion. And you can brief a little.
Thanks, Javier, and hi, everyone. I just wanted to update you on a workshop which kind of had a similar theme, which was held by the Chagas platform of DNDi a couple of years ago. And a lot of people in this room, I think, participated, and also people from the different national reference laboratories were involved. But basically, the theme of the workshop is, we know that we need better evidence in order to support, the potential use of rapid tests. So how do we get that evidence? What is the process that we need to go through? That was kind of the theme of the discussion, and really it raised more questions than answers, I think. But one of the topics that was discussed was the creation of panels, of reference panels. So it's important for each country or each situation to have reference panels that are adapted to the potential, that reflect the potential use of the tests. So the different epidemiological settings, and as Melissa and others were mentioning, the different circulating DTUs that cause so much variation in test performance between different countries. So this document is available through our Chagas platform, and I can share it with anyone. And it has a pretty detailed summary of what the discussion was. Another, I think, important point was doing studies which reflect the conditions in which the tests will be used. So in addition to laboratory-based studies, field studies, and as Maria Jesus had mentioned, we have a field-based study right now in Colombia, which is looking at rapid test performance in pregnant women, thinking of implementation in primary care for that scenario. And also, what's the algorithm going to be? So in addition to getting evidence on the actual performance characteristics of the tests themselves, a lot of people have spoken about low sensitivity. Well, maybe sensitivity can be increased if you're using 2 rapid tests in parallel, instead of using in serial. So I think those were kind of the main conclusions from the workshop, and maybe we can share the document after with everyone in the group. Thanks.
I think you have all the document in a mail that we share with you. So, but anyway, it's available. And finally, there was a more recent meeting held in Brazil by Cuida Chagas and PAHO that they discuss a little bit this issue. And Andrea is going to present the conclusions.
Okay. Some of the people who are here were invited, and we performed this meeting with PAHO and some professionals who work with diagnosis. So we are some questions and more questions than answers, like Colleen, about the use applications and the studies on RDTs for Chagas disease, what has been done, what is planned, and what more we need to be. And some guiding questions, considering the published evidence in these studies. It is possible to change the practice or international guidelines in PAHO in the countries regarding the use of RDTs for screening and or diagnosis of chronic Chagas disease, and what evidence is there on the use of combined RDTs for performing RDTs diagnostic algorithms, and is it possible to compare in using the evidence generated by the published or ongoing studies and the response? We need more evidence to start using RDTs for diagnosis. But however, it's used as a tool for surveillance and screening should be supported. But in one group, we have 4 different groups of specialists, and one group defined that now we lack of evidence even for screening for Chagas disease. It's very important. All the data with chronic Chagas disease, and most of the patients adults, it's important, and it's a point we can not use for children in this meeting, the report, and greater number with several samples, and more recently we use with capillary blood, all field studies in high and medium prevalence areas, most in Bolivia and some in Argentina, and more recently Colombia, and a point that we need to have 2 studies in areas with low prevalence, and most studies evaluated the role of RDTs as screening, and more recently few studies evaluating the combined use of 2 or 3 tests for diagnosis, and it's very important. The RDTs evaluated the StatPac in BIOS, and we have problem now for to get this test, and Wiener and Bioline. And the other question: will the use of RDTs replace the use of conventional tests for diagnosis of chronic Chagas disease? And what are the necessary conditions? Again, the evidence does not support the idea of that RDTs replace the conventional tests. However, it can complement public health efforts to identify the suspected cases for subsequent confirmation. And should RDTs be selected based solely on the sensitivity and specificity indicated by the manufacturer's information, and or should selection be based on performance of a certain brand over others, and what other parameters of or information in addition to sensitivity and specificity are essential to choose the RDTs, and we should not just accept the information provided by the producer, and the national competent authorities must document the sensitivity and the specificity of RDTs. And very important, we need the positive predictive value. So we need to work in different conditions to document the performance of these tests. And it's very important to include the sustainability criteria to assess the product, as well as was a cost effectiveness studies. And sometimes some people talk, how can we use this test that costs $5 against lower than $1 to like ELISA. And finally, if it's necessary, geographic validation, it's because the DTUs before using in a particular region, and yes, we need geographic validation in the country, and sub-region criteria should be used. So we have not so good answers, but believe me, have a meeting with PAHO, Washington, talking about RDTs. It was a step very important. Okay, thank you.
Thank you, Andrea. Well, now now is the dancing time, so we need to find our partner to dance with. Well, challenging answers and challenging questions in this recent meeting. I agree with Andrea to have PAHO sitting down together, even to discuss rapid tests, which that is an achievement. But now the door is opening more and more, like in Argentina, for instance, no? So we are going to write together this position paper. We are going to divide you into groups. The questions is in trying to structure a little bit the draft, help us to think. The first question, or the first part of the paper, will be to introduce a little bit the state of the art. Introductory questions. Can we make progress in mother to child? Remember that we are focusing on mother to child transmission control. We are not talking about rapid tests for adults or whatever. I mean, we are talking about mother to child transmission control. Can we make progress on that? And scaling up people diagnosed with current diagnosis tools. Do we want to screen more or to reach more people? This is the tricky evil question, right? Or do we want to screen better with the highest quality? How we can meet the balance between both? What is civil society waiting from us? What are the patients waiting from us? And previous documents that more or less some of them has been briefed here, and others that you can have in mind that can help us to fit the questions. And the second question, what do we know about current algorithms and how they can be optimized and implemented in the field by overcoming potential barriers? Those are some ideas exposed in your presentations. And finally, the third question, what do we need to know and test in the field regarding new alternative or rapid diagnosis tools? Because one of the challenging answers that Andrea referred was that we need more evidence. Without evidence, we cannot convince anybody to use that. How to generate evidence, how to validate new diagnosis tool, that is something that was mentioned by Colin, and how to scale up the new tools to national and international guidelines. And finally, to sum up the reality and the ideal, the main points discussed. That's why we try to mention or to name that the ideal real. And finally, the conclusions that will be written here by one moderator, and in the group 1 and group 2, and finally in the last 10 minutes we put in the plenary. And those recommendations, those conclusions, if you reach some of them, we'll go to the paper that we will draft and disseminate with you to receive comments, corrections, and whatever. More or less, that is the dynamic. Are you excited to write a paper? Okay.
So thinking about things in 3 steps, second step being cost effectiveness. That's something that I agree we do a terrible job at. And I don't remember the other third one. Make it easy, yes. Yes, adapting it to the context, making it easy for those frontline workers, whoever they might be. Thank you.
So that was the first question? Or, oh, overall, okay. Yeah, we worked with the well, I don't have like the, maybe we can just go to the operational research that we thought about. So we thought about, so we thought about operational research questions that maybe would be interesting to discuss and to put forward for the future. So one of the things that we were saying is about access is that maybe we should couple the testing with the vaccination schedule for small children, since they get vaccinated I don't know how many times during the first year. So maybe we could do a pilot study where we like piggyback the testing to that to see how, if that would improve really access and adherence. Also, we talked about having different control trials in depending on in different epidemiological situations, where you compare the current algorithm to different alternative algorithms, and also using mixed methods. So also incorporate social sciences here to see what are the barriers and facilitators. And also we thought about studies where we were thinking about generating evidence for scaling up of these different things that we discussed, and also the use of biobank samples for testing different tools.
Let me add that in this group also we discuss about we discuss about is there anybody online still waiting there? Yeah. So we discuss about the effectiveness of the MTCT Plus and how that can be optimized in order to use alternative methods and all of that. And we emphasize that the community engagement and how to overcome barriers through the community engagement to scaling up the diagnosis numbers. And if I think this was all, no, more or less. And yeah, and finally the political issue. We need to introduce a strategy of advocacy with PAHO, especially with PAHO, because in our region, PAHO is really followed by the country. So that is the key issue. And when PAHO opened a little bit the door, we need to take the opportunity to convince a little bit more and to rewrite the narrative of the alternative methods in order to convince PAHO, governments, and investors. And yeah, I think it's more or less. Anyway, we will share. I mean, we will put, as I said, we will put the music in the draft. We will share a little bit your thoughts, your ideas, to try to summarize a little bit. I know that we will have the problems of words, because if we say only, it's a problem, if we say whatever, but we will try to disseminate that with all of you, using the gentle support of COR-NTD with the mails and all of that. And in order to try to reach a consensus, we have not an urgent deadline to send that paper. We want that the paper is rich and at least has the common views of all of you. And if we detect that there is a point that it is impossible to agree, we will try to explain a little bit why. But that is the issue. I think for PAHO, for governments, it's important documents that those that you have mentioned. It is important, these kind of documents, especially because they are produced in an event that is well received by decision makers. So that's why it's so important. I take the opportunity to thank the team of Patrick, Joanna, and everybody in the COR-NTD, and for this welcome and these open doors for Chagas Disease. Many thanks.